your hosts. I'm Tobias and this is Will. Together we have a number of curious and exciting topics to share with you.
As attendees of the Hand Eye Supply Curiosity Club, you're all now members, provided you adhere to our philosophy.
Ex Curiositas Scientia.
We pledge to learn without prejudice in pursuit of our mutual goal, perpetual noviceship. We admit that it is impossible to know everything about anything, and thus we remain perpetually curious and perpetually novice.
This is our flag and our mascot, Franklin. The lightning bolt represents the receipt of knowledge, the enlightenment of illumination, the resonance of truths understood. It awakens and excites us and makes us hungry for more. Curiosity Club is made merrier by our fellow artisans at Fort George Brewery in Astoria, Oregon. And now let's give a warm Curiosity Club welcome to Greg Landry, MD, Vascular.
Thanks, that was an awesome introduction. That's the best one I've ever had. All right, well thanks Tobias and Maggie for asking me to talk. I've worked with Maggie now for, I don't know, 5, 6 or so years, maybe even longer than that.
I just appear to have been there forever.
Yeah, it seems like a long time. But anyway, she was the one who kind of told me about this club and asked me if I would speak. And it's kind of fun for me to do this because, most of the talks I give are kind of scientific and a lot of data and graphs and things like this. And it's kind of fun just to be able to talk about what I do and why I do it. So I am a vascular surgeon. And I see I have to scroll down like this.
It's the side-to-side arrow keys.
The side-to-side, okay.
Yeah, like left, right.
Okay, well then this is good. So these are just kind of basically the topics I wanted to cover, sort of what is a vascular surgeon. I think we kind of suffer from a little bit of obscurity, so I just kind of wanted to talk about that. The types of things we do, and I brought some little gadgets and technology here that it's kind of cool stuff. There's a lot of new developments in our field, and I wanted to share some of that with you. So, in terms of what a vascular surgeon is, as I said, we kind of wallow in obscurity a little bit. I don't know if any of you saw The Fugitive with Harrison Ford, but it turns out in the movie, Harrison Ford plays a vascular surgeon. And I don't know if you remember, but in the beginning of the movie, he's at this reception with his wife, and then they're driving home. He gets paid. She has to go in to help do an emergency operation. She goes home. He goes and does a gallbladder operation, which is totally not anything a vascular surgeon would ever do. But anyway, that's what he does. And then he goes home and finds her dead, and you know the rest of the story. But anyway, he was a vascular surgeon in The Fugitive. But that probably doesn't help you too much to figure out what vascular surgeons do. So, I go to a lot of various social functions, and inevitably people say, well, what do you do? And I say, well, I'm a doctor. And they say, oh, what kind of doctor? And I say, well, I'm a surgeon. And they say, oh, what kind of surgeon? And I say, oh, I'm a vascular surgeon. And that's when I kind of start to get the puzzled looks, because they don't really know what that is. So they say, oh, well, that's like heart surgery, right? And I say, no, it's really not heart surgery. Heart's kind of its own specialty in and of itself. It's really not heart surgery. Or else I say, oh, you do like varicose veins. And I say, well, yes, we do treat varicose veins, but that's just a very small part of what we do. So basically what vascular surgeons do is basically treat all of the blood vessels in the body outside of the heart and brain. Heart and brain are kind of their own specialty, but basically any blood vessel anywhere else, artery or vein, that's what we treat. And if you think about that, that's a pretty broad topic. If you look at our circulatory system, all the arteries are matched with veins. It basically goes to all parts of the body, lots of different sizes, lots of different shapes, and we get to treat all of it, which is one of the things that I really enjoy about it. So slides kind of cut off a little bit, but if you look in the neck, for example, the carotid artery goes to the brain, and then the jugular vein is the accompanying vein. We treat both of those. In the arms, the subclavian artery is the main artery that goes to the arm, and then branches and goes all the way to the hand, and then the veins have the same name. Looking in the chest, as the aorta, which is the main blood vessel in the body, comes off the heart, it sort of makes this arch and then kind of makes this question mark shaped blood vessel. And then the vein that accompanies that is the vena cava. Looking further down in the abdomen, this is kind of when it gets a little more interesting and complex. There are a number of branches of the aorta that go to the intestines, to the kidney arteries, and then the accompanying veins have the same name. The big vein, the big blue vein in the abdomen is called the vena cava. So we do procedures that in people who have problems with those blood vessels. And then looking further down in the foot and in the leg, there's a series of arteries that branch and get all the way to the foot, and then their accompanying veins. So it's really a really broad variety of structures that we deal with. It's all over the body. It's lots of different blood vessels of different shapes and sizes. So in terms of what we do, the procedures that we do that we probably treat the most are carotid artery problems, aneurysms, leg artery disease, and vein disease. And I'll talk a little bit about that more in a second. So, you know, people sometimes ask, well, how'd you get interested in this? Like, given the fact that this is relatively obscure, how did you ever become interested in this sort of thing? And as I think about it, it's hard for me to say exactly when that occurred. But as I look back, when I was a kid, you know, my parents got us the World Book Encyclopedia. And of course, encyclopedias are kind of obsolete now, but at that time, that was like the font of knowledge. And if you look at the old World Book encyclopedias, like from the 1960s and 1970s, and go to anatomy, they have like these cellophane pages like this, where as you turn the pages, it kind of peels away different structures until you get to the internal organs of the body. And I remember just looking at that when I was a kid and thinking, this is really cool that there's all this stuff going on inside of me that I can't even begin to comprehend. So that was kind of when I first started to think about doing something like surgery. And then when I was in high school, I read this, I actually found the actual magazine that I read that really inspired me. This was a Life magazine, August 1st, 1979, so I would have been like in high school at that time. And there was this article about this, I don't know if you can read this, but it says, Miracles of Microsurgery, Sewing People Back Together. And it was this article about this microsurgeon who was like reattaching severed limbs. And I remember reading that in high school and just thinking, wow, that is just so cool to be able to do that. And you know, he was talking about doing these operations that would take like 24 hours, and he would be awake the whole time, which of course now is a thing I just hate. But at the time, I thought, wow, that would be so cool to, you know, to have that sort of ability to do that sort of thing. And then, you know, as much as I hate to admit it, I'm sort of a product of the television era, and I probably watched a little bit too much television when I was a kid. But anyway, one show that really kind of influenced me was MASH. So again, as much as I hate to admit it, watching MASH and, you know, seeing the humor of it was a comedy, so there, you know, there was a humor, but then also just kind of seeing their dedication and their humanitarian, the way they approached their caringness, all that really had an influence on me. So, so at that point, I was in high school. I decided that's what I wanted to do. And then I went to undergrad and medical school at the University of Wisconsin, which is in Madison. That's Madison, Wisconsin. Hopefully that shows up. But you know, I don't know if any of you have ever been there, but it's really a beautiful city, and it's surrounded by water, which, you know, people don't think of the Midwest as having all this water, but Madison is kind of surrounded by water. So, you know, I was going to school and also taking advantage of all this water, and I started out sailing, and then I got kind of bored with sailing and took up windsurfing. And then when I started windsurfing, I got really hooked on that. So I went through undergrad and then medical school, and then in medical school, you know, you have to match into a residency program. So you go around and you interview, and then you rank all the places you want to go, and they rank you, and then they throw it all on a computer, and wherever you end up, you end up. So during medical school, I actually went to Hood River for a vacation for a week, and this is windsurfing out on the gorge, and this is so much different than windsurfing in the Midwest. I mean, it's a whole other level. So I thought, you know, if I could go there, do my residency there, and be able to windsurf at the same time, that would just be fantastic. So, and fortunately, that's kind of how it worked out. I matched up at OHSU and started there in 1991. And there's OHSU right there. And I haven't left. So I'm still in the same place that I was 25 years ago when I first started training. So when I started out in surgery, I didn't really know exactly what I wanted to do. I knew I matched into surgery, but I didn't match into any specific type of surgery at that point. But the more I kind of tried all the different specialties for the reasons I kind of talked about, just, you know, all the variety and the technical aspects of vascular surgery were what really attracted me to it. So I started out as a resident, did my fellowship there, and have been there ever since. So anyway, that's sort of how I came to do what it is that I now do. So there's really two processes that can make arteries go bad. One makes them narrow, and the other one makes them big. So the process that makes them narrow is a process called atherosclerosis. And if you look at what that means, what the Greek means is atheros is porridge or gruel, and sclerosis is hardening. And that, you know, is really the perfect word for this, because basically what's happening is you're getting this hardened gruel in the walls of your artery that over time builds up and initially can kind of constrict the blood flow, but then eventually over time can completely block blood flow. And then the other thing that can happen to arteries is they can get too big. So, and that's called an aneurysm. So the circle in the middle there shows the aorta, which is the main blood vessel in the body, which normally should be a relatively perfect cylinder all the way down. But on the right side of the screen there in that circle, you see what happens with an aneurysm. It kind of bulges out. And just like a balloon, as it gets bigger and bigger and bigger, it reaches a point where it becomes weak and it can burst, which is obviously sort of a catastrophic problem. So those are kind of the two processes that affect arteries. And people always want to know, well, why did I get this? How come this happened to me? And I've sort of depicted here some of the main risk factors. And the two on the top are the two big ones: smoking and diabetes. Fortunately, people are smoking less, but still about 20% of the adult population in the United States smokes. And if you look worldwide, it's 50% in China, 50% in Russia. So there's still a lot of people that smoke, and that's really the biggest risk factor. So if you're a smoker, sorry, but you really should quit. And then diabetes is the other thing, and which is something we're seeing more and more of now, because as people are quitting smoking, that part's going away a little bit, but the American diet is horrible. So all of the Cheetos and Coke and Big Macs, it's just causing an increase in diabetes, both in the United States and throughout the world. So that's something I think we really do need to work on. And then there's genetic factors. You can't really blame too much on your parents, but some people are sort of genetically predisposed to getting blood vessel problems. High cholesterol is a risk factor for it. And the thing we're probably seeing the most now, actually, is that people are just living a lot longer. When I started out, it was very unusual to do operations on someone older than 80. And now, the people in their 80s are probably about the biggest group that we are treating. And we're treating people in their 90s and even people into their hundreds now. And the reality is people are getting older, we're living longer, but things break down, things wear out. And even in people who have been pristine in all other aspects, as they get into their 80s and 90s and hundreds, their blood vessels start to break down. So then people want to know, well, how would I know if this is happening to me? And it turns out with the artery narrowing, usually that's not too hard to figure out. So looking at some of the different arteries and some of the symptoms they can cause, the carotid artery, again, which is the main blood flow to the brain, if people have narrowing in that artery, the worst thing is it can cause a stroke. But fortunately, most people before they have a stroke get warning signs of a stroke, which we call a transient ischemic attack, or a TIA. And these include things like temporary paralysis, loss of vision in one eye, or trouble speaking. Now, the important thing to remember about TIAs is they tend to affect just one side of the body or the other. So people sometimes get very worried because, for example, they feel dizzy, or they felt weak all over, or they're having trouble with their memory. You know, fairly non-specific things that don't suggest one side of the body or the other. And those really are not warning signs of strokes. The warning signs of strokes tend to affect one side of the body or the other. So stroke is still the third leading cause of death in the United States. Over 700,000 strokes in the United States each year. And it's a very, I think it's probably the thing that people fear the most. You know, I think people can handle the concept of death. They can handle the concept of certain disabilities. But having a stroke and having all the morbidity that goes along with a stroke is probably the thing that scares people the most. When blood vessels in the abdomen become narrowed, it can cause a couple of different symptoms. So there are arteries that go to your intestines. And if those arteries become narrow, what happens is that people tend to have pain when they eat. And it can get so bad that every time they eat, they just have excruciating pain. And as a result, they lose a lot of weight. And probably one of the more rewarding things that we do, even though this is kind of a rare problem, is treat people with blockage in the intestinal arteries. Because, I mean, it's great. You'll do this procedure, you'll fix those arteries, you'll have this skinny little person who just looks like they've wasted away to nothing, and you'll see them 6 months later, they've gained 30 pounds, they're plump, they're eating. It's just very rewarding to see that transformation just by fixing those arteries. And then arteries that go to the kidney arteries, if those become narrow, those typically present with high blood pressure because your kidneys produce hormones that regulate your blood pressure. So if the blood vessel to the kidney is narrow, the kidney will interpret that as a lack of blood flow. So the kidney will produce hormones to increase your blood pressure to try to get more blood flow. So that's usually how people with kidney artery problems will present. And then leg artery disease, another word for that is called peripheral arterial disease, or PAD. And this affects about 10% of the population in the US. And it's kind of a spectrum of symptoms. It starts out sort of as a pain when people walk. We call that claudication. So what happens is they walk a specific distance and their legs start to cramp up and they have to stop, and then the pain goes away and they keep going. And over time, as that gets worse, that distance that they can walk becomes less and less and less. And then the more severe form of peripheral arterial disease is what we call critical limb ischemia, which includes things like rest pain or ulcers, or in severe cases, even gangrene, where basically parts of the foot or even the whole foot can die because of lack of blood flow. And you know, people kind of underestimate how severe some of these problems can be. So this is the only graph in the whole talk, I promise. So this is just, I'm trying to see, I don't know how this is going to best be in the middle of the screen there. Okay. So, you know, if you think about different forms of cancer, everyone understands cancer, everyone knows about cancer, everyone's heard about cancer, everyone's read about it, everyone knows someone who's had it. So it gets a lot of attention, and it should, because it's a big problem. But if you look at survival rates of people with various forms of cancer versus people with peripheral arterial disease, or PAD, you know, the survival rates are not that much better, and in many cases worse than many forms of cancer that immediately strike fear in our hearts. So if someone says they have a certain form of cancer, you immediately empathize with them. If someone says they have peripheral arterial disease, you know, you may not have the same level of empathy. But it's something that really should be more on people's radar, because it does lead to a lot of problems and early death in people that have it. So although I'm a surgeon, one of the things I've always enjoyed about vascular surgery is that for many people, we're also kind of their primary care doctors. They kind of look to us for advice, not just about what procedure they should get, but just sort of how they should live their life. And so for leg artery disease, we always emphasize non-surgical treatments first. Exercise, smoking cessation, healthy lifestyle, medical therapy. That's always the first choice of how we treat these people. Now, for people in which things get more severe, we can do operations to try to improve the blood flow to their leg. And this is called a leg bypass procedure. And I'm just going to kind of go over what that involves. I have not too many gory pictures, but a few here. So hopefully, if anyone feels squeamish, there's just a few pictures here that you may not like. But anyway, when we do a leg bypass procedure, it's to treat blockage in the artery in the leg. So in order to fix that blockage, we use a vein in their leg that is a nice long straight vein that is otherwise not necessary for your circulation, a vein called the saphenous vein. And that's marked out in the black line on that person's leg. We have a couple of different ways to use that vein. Sometimes we'll make small incisions and we'll kind of mobilize that vein. On the picture on the bottom, you can see the little black spots. Those are little ties on the branches of the vein. So the first step is just to get that vein ready to use. Now, more and more now, I try not to make the big, long incisions because it's just more things for people to heal. And we can harvest or remove that vein using a scope. And that's called an endoscopic vein harvest. So instead of long incisions the whole length of the leg, we can just make one little tiny incision and use this little scope to mobilize and remove that vein. Then after the vein is out, we still sort of have to prepare it for use. And basically the way that we do that is to flush the vein with usually just the patient's own blood. We flush the vein out, all the little side branches we tie off so that you have this nice long piece of tubing from the own person that you can use to fix their blood vessels. Sometimes you have to sort of splice veins together. You might not have a long enough piece, so you have to take a couple pieces and splice them together. These are just some pictures showing that. We basically use these kind of angled scissors to make a couple of slits in two veins, and then we sew them together with a very, very fine suture. That suture is probably about the width of a human hair. It's a very, very fine suture. And then that gives you a nice long segment where you started out with a bunch of segments that were much shorter. This is where it gets a little bit gory. So the next step is that you have to create a tunnel for this vein, because the tunnel has to go from the artery that you're starting from and then go to the artery that you're going to. And I brought the tunneler here. This is the actual device that we use. So that's the metal rod that you see on the picture there. So it's basically just a hollow tube. It's steel. I mean, this is a very robust device. And then
What's the diameter on that thing?
it's probably about a ½ inch or so. So this actually goes through the leg. So it starts on one end of the leg and comes out the other end of the leg. And then after you get it in position, the handle comes off. And you can see there's a little, I don't know, maybe you can't see that, but there's a little knob on the end there. So we tie the vein to this little knob here, and then this part screws off. And then as we pull, we basically just pull the vein through that tube. It's just a hollow tube. So the vein goes through that hollow tube. And then after the vein is through that tube, the tube comes out and the vein stays in its tunnel. So it's kind of people are oftentimes alarmed when they see this device. But I mean, it's a very effective way.
Well, most of them are out of it.
That's right.
You don't show it to them beforehand.
No, we don't show them this. This would
Of course,
probably.
we're all terrified for one.
Quick question.
Yeah.
What's your optimistic half-life on having that part out of the body, having that vein out? Like how much?
Oh well, we keep it in we keep it in a chilled liquid, and it can stay out for. I mean, usually when we take it out, we're pretty much ready to use it right away. So we probably use it within an hour. So, but you could probably keep it out for maybe 2 or 3 hours, and it would be just fine.
Strange to think about.
Yeah, as long as it's obviously going back in the same person. So, as opposed to a transplant where you're putting an organ from someone else in, using a vein from that individual person probably like 2 or 3 hours would be just fine. But usually it's within an hour. Once we take it out and have it prepared, we're ready to go and just put it right back in.
How come the leg doesn't miss the vein?
Well, that particular vein is not critical for your circulation. It's the same vein that the heart surgeons use when they do heart bypass surgery. It's a very long, straight vein. It just starts in the top of the leg and goes all the way to the ankle. And but it's not a critical vein for your circulation. So you can take it out and people never miss it. So then once the vein is out, as I said, we're sort of ready to go at that point. So in this picture, that just shows the artery that we're starting to bypass from. All those little white loops are little rubber loops that we put around the artery and all the branches so that we can tighten those, and that shuts off the blood flow to the area that we're working. And then you can make lots of different configurations of the grafts, but in general, they tend to start above the knee and then go to some artery below the knee. There's lots of different ways that you can configure that depending on where you're going. And then how we sew the vein to the artery. So in this picture, the vein is the blue thing, and the artery that we're sewing into is the red thing. So we make a little incision in the artery, and then again use very, very fine suture to just sew the vein to the artery. And I can use this as a pointer here. So that this is the vein right here sewn to the artery, and that's the top part, and there's the bottom part right there. So we have to sew in the top, sew in the bottom, and the middle part, of course, is where we put the tunneler through, and the rest of it sits in that tunnel.
So does that heal and seal really well eventually?
It does. I mean, you'd think that there'd be a lot of bleeding where you've been sewing this vein to the artery, and it maybe bleeds for maybe a few drops of blood for maybe 10, 15 seconds or so, and then it's usually sealed pretty quickly. It heals in pretty solid. Sometimes if people don't have their own vein, we'll put in an artificial tube. Those tend not to work quite as well. They bleed a little bit more initially, and they don't last as long. So almost always, if there's an option to use people's own veins, that's what we do.
So what happens to the artery? Once the artery is being bypassed, does it just continue to just sort of, does it atrophy, or what happens?
The artery that's been bypassed?
Yeah, what happens to the artery itself?
Not much. I mean, it's already filled with plaque, so it'll basically just sit there. There's no reason to take it out because it's not hurting them, but by the same token, it's not really functioning either. So it's okay for it just to sit there. Yeah.
So possibly naive question, why can't you go in there with like a pipe cleaner and just...
Oh, good. I'm going to get to that. I'm glad you asked that. That's coming up. So Maggie wanted me to talk about this. You know, we have some kind of colorful patients every now and then, and one day I was talking to a patient who needed this operation. He's like, "Oh, that's great. I'm glad you're going to do that because I need better circulation." He said, "But I want you to do my operation with obsidian." And I just thought, what? That sounds crazy. But anyway, he was explaining it to me, and he actually brought in some little obsidian knives that he had made. And I said, no, I'm not going to do that. It just doesn't seem, it seems crazy to me. And well, I didn't say that, but I said, that's just not how we do it. And I don't know how I could get something like this sterile. It would just be a real big hassle. So he said, fine, do it however you want to do it. But he's like, I want you to kind of look into this a little bit, and you'll understand why I wanted you to use obsidian. And if any of you want to hold on to these, feel free to do that. But the reason I have them in these little plastic bags is because they are crazy sharp. This is the sharpest thing I've ever felt. And this is just so I did a little research on it, and it turns out that. So this is a scanning electron microgram of obsidian, and this is a scalpel. That's actually an actual stainless steel scalpel. And I think even the people in the back row can see a pretty big difference between the obsidian and stainless steel. And it turns out that going way back even to around 2100 BC, people used obsidian to do surgery. That's what people used. Now the downside of it is that it is brittle, so it has good linear strength, but it doesn't have good lateral strength. So if you put any lateral pressure on it, it'll tend to break. And the other thing is that it's very expensive. So it turns out you can actually get obsidian blades, but they cost about $81 a piece, which may not seem like that much, but in comparison, a stainless steel surgical blade costs about $1. So it's about 81 times more price. But anyway, patients always or very frequently come up with ideas, and one thing that this guy taught me was that you should never sort of discount someone's ideas, even if they sound a little bit fringe and crazy. And sometimes people come up with some real good ideas. And obviously, this is something that's been done for several thousands of years, so there was certainly some validity to it. Occasionally, people have some kind of crazy ideas, and I don't know if any of you remember this, but 10 or 15 years ago, there was this big magnet craze, and people were putting magnets in their shoes, and it sort of made sense because the theory behind it was, well, there's iron, or blood has iron in it, and iron is magnetic. So if you have a magnet in your shoe, it's just going to pull all that blood into your foot, which kind of, I guess, made sense a little bit. But anyway, it was kind of a craze that sort of came and went. But at one point, we had all these people coming in, and they must have all seen the same late night infomercial, and they had these little it was basically a shoe insert. It was it was like one of those Dr. Scholl's things, but it was a magnet that they would put in their shoe. But anyway, I haven't seen that in 5 or 10 years. But occasionally people have some kind of odd ideas. So getting to your question, there are some methods and techniques now that we can use to just kind of clean plaque out of arteries. And these procedures are done a little bit differently. They're done in what's called an angiography suite, where we have all this X-ray equipment. And then we can put small catheters into the arteries to reopen blood vessels. And there's a number of different tools that we have available to do that. We can do what's called angioplasty, where you just use a balloon to stretch the artery open. There's also, basically, we kind of refer to it as a roto-rooter. It's basically just a scraper that has a little drill that scrapes plaque off the artery. There's lasers that will actually just kind of laser right through the plaque. And then there's also things called stents, and I'll be talking more about stents in a second, which are just metal scaffolding that goes in the artery to sort of brace it open. So all these things sound attractive, and there's certainly a role for all of it. The problem with most of these procedures is that they just don't last as long. So whereas if you do a leg bypass procedure, there's a good chance that it'll last several years. Most of these procedures last maybe a year or two, so they just don't have the same level of durability. But clearly all the technology now is going towards these types of procedures, and we're starting to see now people adding drugs to these stents so that the drug kind of infuses into the artery. There's lots of technology that's being developed, so eventually this will probably be primarily what we do, but there's still a role for doing leg bypasses like I talked about before. And these are just some examples. So this is an artery in the abdomen. You can see the two narrow areas there, and that's after putting 2 stents in. And this is looking further down the leg. This is just a picture of the artery, which doesn't really even look like an artery. It's just kind of got lots of plaque and irregular areas in it. The middle one is after just treating it with a balloon, so that's angioplasty. Looks a little bit better, but still not great. And then the one on the far right is after putting stents in, and the stents kind of go between the 2 arrows. So again, it's a really great technology. It's one that we do a lot, but you have to sort of understand what your expectations are. So if you're going for more of a short-term fix, this is probably the best way to go. For someone where you really want a good long-term fix, Even though it's a bigger procedure, the surgery is probably still a little bit better. So I'm going to talk a little bit now about aneurysms. And the place where aneurysms occur the most are in the abdomen. It's not the most common thing, but still the 13th leading cause of death in the US. And the thing that we worry about the most with aneurysms, as I mentioned, is that they can get weak and rupture. And that still occurs about 50,000 times every year in the United States. So this is a little bit blocked here because of the animation issues. But anyway, sometimes people want to know how would you know if you had an aneurysm? So before, when I was talking about blood vessel narrowing, there were always clear warning signs depending on which blood vessel was blocked. The problem with aneurysms is that you typically can't feel them. You don't even know you have them. So, and usually you don't know you have them until they burst, but by then it's often too late. So with aneurysms, as opposed to some of the other things, we are more diligent about doing what we call screening. So if we think someone might be at risk for aneurysms, so basically older people, men, people who've smoked, people with a family history of aneurysm, we do ultrasound screening. And this is just an ultrasound showing an aneurysm. These numbers on the bottom are the measurements. So normally, the diameter of the aorta should be about 2 to 2.5 centimeters. I think you can see, well, maybe you can't read this here, but this is about 6.4, 5.7 centimeters. So about 2 to 3 times the normal size that it should be. In terms of how we fix them, the operation that we do is kind of a big operation because the aorta is in the abdomen. There's a lot of stuff over it. There's a lot of stuff around it. So to get to it is kind of a big operation. But it's actually an operation that works quite well. Basically what's done is after we sort of isolate the aneurysm, we put these clamps, they're pretty big clamps, that go above the aneurysm and then below the aneurysm. And then we sew an artificial graft or tube into where the aneurysm was. And then actually the tissue that used to be the aneurysm, we wrap around the graft. And that sort of isolates the graft from the rest of the body. So that's sort of what we call an open repair. But I have a bunch of different models here that I'll show you in a second, and actually some devices that I can deploy for you. Another method of fixing it is called endovascular. And this is a method where through very small incisions, usually in the groin, we can put stents, much larger stents than what we put in the leg, but stents up inside the aorta to seal the aneurysm off. So the thing about aneurysms is even though they're not that common, occasionally they happen to famous people. And these are just some examples of people who died from ruptured aneurysms. So this was Charles de Gaulle, who, I never realized this, but he was like 6'5". He was a real big guy. And actually we tend to see aneurysms in taller people. But anyway, he died of a ruptured aneurysm. George C. Scott, who's in the middle, Lucille Ball, and then Harvey Korman, who, does anyone remember Harvey Korman? You have to be a little bit older to remember him. Carol Burnett show. I bet no one knows this offhand, this person. Hmm?
It's Ricky Nelson.
No?
No. Jim Vincent?
No, it's Conway Twitty. So Conway Twitty died of a ruptured aneurysm. John Ritter, that was kind of that made the news a few years ago. He didn't have an aneurysm, he had what's called an aortic dissection, which is very similar, but a little bit different. What happens in an aortic dissection is that instead of the aorta enlarging, the aorta actually has a number of layers to it. And what happens in a dissection is those layers separate. And because those layers separate, it creates a weak spot that can then rupture. And that's what he died from. And then Albert Einstein. And Albert Einstein's story is pretty interesting, actually, because he had, in 1948, went to the hospital with very bad abdominal pain. And at that point, none of this technology existed, none of it. So he had really bad abdominal pain, and according to the surgeon, had an aneurysm the size of a grapefruit. And so they operated on him, but at that point, again, they didn't have any of these grafts or stents or anything. So what they did was to wrap the aneurysm with cellophane. And the thought was that the cellophane would create this real intense inflammation around the aneurysm, and it would strengthen it. And he actually lived 7 years after that. And finally so his initial operation was 1948, and then he died in 1955. So finally in 1955, his aneurysm ruptured. At that point, they actually had the technology to do the surgical repair. The first ones had been done just a few years before. But he said he didn't want that he had lived a good life, and he knew what was happening to him. He was happy with the life he had lived, and he didn't want to undergo anything else. So he died of a ruptured aneurysm. But there are some people who actually survive and have had aneurysms treated and have survived. So Bob Dole had a aortic stent placed and survived. Dick Cheney actually had an aneurysm behind the knee. It's called a popliteal aneurysm, and he had stents. He had them in both legs actually. He had had stents placed in those. Roy Rogers had a open surgical repair of an aneurysm. I believe he was like age 78 or something like that, but he lived till about 85, so he lived another 7 years after that was repaired. And Bob Euchre just recently actually had a stent placed in his aorta. So just to kind of show you or give you an example of what these stents look like, I brought some props here. So this is not exactly to scale, but it can kind of give you an idea. This is a stent that is pretty unique actually. Most of the stents in the aorta start below the kidney arteries. This particular stent is unique in that, so these are obviously the kidneys right here. These are the arteries that go to the kidneys, and these are the arteries before that I was talking about that go to the intestines. So again, most of the stents start below the kidney arteries, but this stent has little sleeves put into it that provide blood flow to the kidneys and can also provide blood flow to the intestinal arteries. So actually this particular stent is currently investigational. It's not available in the United States. These types of technologies tend to get approved in Europe and Canada first. The United States is a little bit behind in terms of approval of stents. That's just the way the FDA works.
So does that go inside the arterial wall? Or
It does, yeah. This is all inside here.
And then it's water or blood tight?
Right, so, and I'll show you here in a second. I've got some other examples, but basically it seals up at the top above the aneurysm, and then it seals down below, below the aneurysm, and blood goes through the stent. We've got a few more props here. This is a stent that is designed to go into the thoracic aorta, which is in the chest. So this is a little less complex. It's basically just a tube. So the thoracic aneurysms in the chest they tend to be a little simpler in terms of not having as many branches to deal with. You can see on the picture on the right there's a lot of curvature in that artery. So I brought some more things here just to show you. These are some actual stents. And I'll show you a few now, but if anyone wants to come up and take a look at these at some point, that's fine. So these are examples of stents that would go up in the artery in the chest. So that's a big device, right? But I mean, that's up in the chest. These are the types of sizes that you need in order to seal things off.
So where do you access to insert that? Is that
These
through
all
the
go
leg
in
or
through
the
these go in through the leg.
Wow.
Yeah.
Does that expand? I mean, when you insert it, it's not that diameter, is it?
What's
It
that?
expands once you put it in. Is that right? When you insert it, I can't imagine you shoving a 1.5 inch diameter thing up there.
No, I'll show you here in a second. I have a few demos to show exactly how they go in. But these again are ones that would go up in the chest. Once you get down into the abdomen, they're a little bit smaller. Still pretty big though. And then this particular one is one that can accommodate different branches that go to the kidney and intestinal arteries. And then of course they have to go down into each leg too. So all these are kind of assembled inside the body. So that this would be an example of a top piece that would go in. And then they have these little extension limbs that go in that kind of telescope inside. So you basically just build these stents inside the person.
So do you sew them together as you put them in?
No, this is all. So this is all done just through the leg, and they're held.
You shove them up in there and then they bond together.
Right. They telescope inside each other and seal with each other. So this is what they're put in through. This is an example of what we call a sheath. So this would go in through the leg. It's got, the first step would be to put a wire up. We have very long wires that this goes over. So this would go in over the wire, and then it's got what we call an introducer here. So this comes out. And then again, you just have a hollow tube here. So that hollow tube would sit in here just like this, and the stent would go through this hollow tube. So, so this is an example of a stent that would go up into the chest. So again, it's got to be very long because you're starting down here. I'm about, I don't know, 6'3" or so. So, I mean, it's got to, in the arch of the aorta is probably right about here. So this has to be long enough that we can put it in through the groin and still have it reach all the way up to the chest. So what we do, again, is this all goes in over a pretty strong wire. It sits up, and then we use x-rays to sort of, this has little metal markers on it that kind of help us identify exactly where the top and bottom of the stent is. We do some x-rays to identify all the different arteries so we know exactly where we want this to land. Then in this particular one, once we have it in the right position, this blue outer part is what's called the sheath. So the stent is actually inside this right here. And this gray part here is what we call the introducer. So you see the gray part sticks out the end here, and then it sticks out the end here. So once we have it in the right position, we basically just pull the sheath back, and you'll see the stent start to pop out here. It kind of comes out like that. And then, so it's still, at this point, there's just a tremendous amount of blood flow here. So the way that this is designed is it's constrained at the top, because if it fully opened up right off the bat, it would just be like a windsock. And there would be so much force in it that it would just push it back. So it stays constrained at the top, and then once the bottom part is down, it's got a little, like a little trigger wire here. So we undo this part. And this little green thing has a little trigger wire on it. So as I pull this back, it's going to release that top cap. If I can get it released here. There we go. So as I pull this out, those wires come out, and then it releases the top cap. So obviously in the body it would stay in place. But
Just ran $20,000 worth of insert.
yeah, these are sort of shockingly expensive. But then, again, if you want to come up and look at these, be very careful, because these have little barbs all around the top, and they're very, very sharp. But that's so the two things that kind of hold it in place are just the radial force. So we measure the diameter of the aorta, and then this is oversized by, say, usually about 10 to 20%. So a little bit bigger than the aorta, so it exerts a little bit of radial force. But then it also has these barbs on here. And again, as I said, the barbs are very sharp. So if you're going to grab it by the middle. Don't grab it by the top, because that's where those real sharp barbs are.
Does some scar tissue form around those barbs? So sort of like
It just kind of hooks into the aorta. I mean, they're not so aggressive that they would damage the aorta, but they're sharp enough that they kind of grab it and just kind of hold it in place.
So are our veins that big?
Well, again, this is one that's designed to go up in the chest. So this would be up in the aorta in the chest. But I mean, this this also is designed to go up in the chest. So this would be actually up on the small side. More often they're going to be more like this size. So, but this is, as I said, we oversize it by about 10 to 20%. So, for example, I think this is 34 millimeters. So this would be designed to go into an aorta that would be, say, 3 centimeters or so. And 3 centimeters up in the chest, that's a pretty normal size. So that's just that's that type of stent. But I wanted to show you another one here too. So, so this is one that's designed to go into the abdominal aorta. So like this right here. And this particular one is one that's been on the market for a long time, so it's designed to go below the kidney arteries. So, so there's going to be 2 pieces. There's going to be one that goes in through one leg, and then the other one goes in through the other leg, and you have to sort of assemble them inside, right? So the big piece goes in first. You'll see what the big piece looks like here in a second. So again, we put this up. This particular one would go through this type of sheath here. So we'd already have this in place. And then this would go through that sheath. The way these are packaged, they have a lot of extra packaging material on them that we take off. And then this has a little metal stylet in the middle here too that I have to take off. And this is just a this is all just part of the packaging. It doesn't have any function or purpose. But anyway, once this is positioned, the first step is to just kind of release the top part of it. So this is kind of a bulky device, but basically we just take this and we pull this off. And as I pull this off, you'll see it kind of open at the top there. Okay. So at this point, the top part's open. But this particular, so this is the top part. Again, it has these kind of sharp barbs, much smaller than the one we just opened again, because this is going into a smaller blood vessel. And it's got, it's kind of like a pair of pants with a short leg and a long leg, right? So this is the short leg. The short leg's opened up. The long leg is still constrained, okay? The nice thing about this one is that after you put it in, if you're not happy with where it's landed, you can reposition it. And I don't know how well you'll be able to see this, but try to keep it stable. As I turn this knob here, it will reconstrain the top. I don't know if you can see that or not. So now that top part's constrained, and that allows you, if you need to move it up or down a little bit, you can do that. And then once you're perfectly happy with where it is, you can open it back up again.
How long does one of those surgeries take?
Well, about 2 or 3 hours. Yeah, they're not too long actually. The advantage is you don't have to make a lot of long incisions. In fact, most of these now we're doing through just 2 incisions that maybe about a centimeter or so. So they get done with this and all they need is 2 Band-Aids.
And how are you viewing the placement of the stent?
So that's all with x-rays. So they're on an x-ray table. These, again, if you look at these, there's a lot of little metal markers on them. And so because we can't see the stent, but we can see all the metal markers. So we use the metal markers to position it in relationship to all the other blood vessels in the abdomen. So then once you're happy with with where it is, you can complete the deployment. And basically, it's got a little knob here that I'm going to turn. And that's just going to, all that is doing is making it so that I can no longer constrain it. So this whole piece here, these 2 metal wires, all they were doing was allowing me to constrain or release the top. And then once we're all set, we just pull this cord and you'll see the whole thing will just open up. Okay, so then at this point, this would be inside the body. You'd have the short leg and the long leg. And then just to answer the question of how these kind of stay together, this would be the opposite, the piece that goes in the opposite leg here. So we would have a wire that would be going up into this leg. We put this inside of that one. And then when we deploy that, this is just a little screw tab here.
And its little barbs will go into the stent?
This one, the only barbs are at the top.
Okay.
They're just at the top.
So it's just pressure?
Yeah, this is just radial force that holds these together. So we unscrew this. And after I get it unscrewed, we can open that, and that whole, and that opens up inside the other one, and that all comes out.
So are they deducting all this from your paycheck?
No, I actually, when I knew I was giving this talk, I talked to a couple of the companies that make these, and they were very generous to donate a
Very
few
cool.
devices for me to deploy for you.
What
Yeah.
is the fabric that is? I see.
So it depends on, it's different companies, it's different. So these particular ones are, the fabric is like a polyester. It's called Dacron, it's a type of polyester. And the metal is stainless steel. On this particular one, this one's made by Gore, so the fabric is actually Gore-Tex. And the metal is it's a metal called nitinol, which is a nickel titanium alloy. So it's completely non-magnetic. And that, people always want to know that. They're like, well, will I set off airplane detectors? Can I get an MRI? And all these things are, they don't set off airplane detectors, and they're all MRI compatible.
So do you have to take immune suppressants when you have these things in your body?
No, no. We do usually have people take an aspirin because
That's pretty high tech.
because this is a foreign material, obviously. So at least when it's initially deployed, your platelets will tend to stick to it, and that can form clot. So we have people take an aspirin just to keep the platelets from sticking to it.
As a thinner.
Yeah. So usually, and most people who need these types of repairs are already on aspirin, but if they're not, we have them start taking an aspirin. That's pretty much it in terms of like the medications they need. We do use, while we're putting it in, you know, these devices are pretty large, so while we're putting it in, we do use some pretty strong blood thinners while we're actually putting it in and we have all the devices in. But then once this is in and we take everything out, we let all the blood thinners wear off and just treat them with aspirin.
What?
No, go ahead.
What is the cause? Like, these seem like fairly robust, and I assume I've had a Gore-Tex jacket for 10 years.
Mm-hmm.
It's just fine. What about being in the body causes them to break down or not last? You're saying some of these artificial.
Oh, well, these stents, actually, that's not so much of a problem. These are what we call covered stents, and they're going into big blood vessels. So stents in big blood vessels tend to stay open for a long time. I mean, they're not perfect, and some of them do plug up over time, but you know, a stent in a blood vessel this big, most likely it's going to be good forever. I can show you the difference here, actually. I brought a stent that goes into the leg. And so this would be an example of a stent that goes into a leg. I mean, it's just, I mean, it's long, but it's a tiny little thing, right? So these are the ones that tend not to last as long. So yeah, I mean, the leg's always bending, so I mean, they are quite flexible, but the leg's always bending, so sometimes there's metal fatigue and they fracture. And it's just a much smaller blood vessel with a lot less flow in it. I mean, there's a huge amount of flow that goes through something like
I have a
this.
stupid question. Why do we get plaque buildup in the arteries but not the veins?
It's just a different anatomy altogether. The arteries have a bunch of different layers, and as opposed to the veins, which are much more thin and don't have all the layers that the artery have. But the arteries have a lot of muscle in them. It's not the same muscle it's not skeletal muscle, but there's a type of muscle called smooth muscle that allows your arteries to expand and contract. Because every time the heart beats, your arteries expand, but then they have to contract back to their normal size again. And the plaque tends to develop in that smooth muscle layer. So it's not, it tends to be sort of within the walls of the artery that the plaque develops. So, but that's where no one really knows why that happens. I mean, everyone knows that cigarettes are bad, but no one knows why they're bad. But that's
endoscopically, like lasering or scraping off that, you're actually taking off some of the wall, and then that's going to have to heal, right?
Right. So as you, like, let's say you ran a laser through this artery and then put this stent in, you're still leaving some disease in the artery, and that disease tends to reform over time. But again, veins just don't have that muscle layer, so whatever causes that muscle layer to go bad and form plaque, veins just don't have that. Yeah.
So, I mean, what is the plaque? Is it like the same plaque as you go to the dentist, or is it just?
Yeah, it's hardened gruel. it's a lot of it is calcium, so it's like bone.
Oh, okay.
So a lot of it's very, very hard, like bone, but some of it really is almost like toothpaste. It's like a lot of times the plaque will have kind of this very hard shell, but then underneath that is kind of this very soft, almost like a toothpaste consistency.
Got a crust on it.
So it's a lot of probably the two main things are it's a lot of cholesterol and a lot of calcium. Those are the two main things in it.
So if you do a bypass, though, you're using a vein to take the job of the artery. Is that going to have a hard time because it's not as muscular of a...
Well, it's interesting because over time, the veins, once you sort of make a vein act like an artery, it starts to resemble an artery. And over time, it tends to thicken. So it adapts to that increased pressure.
I have one more question.
Yeah.
What's your thoughts on stem cell arterial generation? Like just making a piece of artery rather than doing a bypass?
Yeah, that's a whole other talk right there. Boy, that's a great topic. And we've been involved in some stem cell trials to try to literally grow new blood vessels in areas where blood vessels don't exist. So far, there's sort of two different ways of doing that. One is to actually take stem cells and to either people's own bone marrow or adult stem cells and just inject those into an area that doesn't have much blood flow and just kind of hope that because there's not a lot of blood flow there that those cells will respond and form blood vessels. And then the other way is to actually try to alter people's genes. So to give them substances that will insert themselves into their genes and create genes that will grow new blood vessels. And there's a lot of research in both of those things. But so far, they've worked well in like rabbits and mice, but nothing has worked in humans well enough.
I was thinking along the lines of like, oh, you've got this part that's off, and you take the stem cells of that part and just harvest it.
Well, right. So that's the other area that's an area of pretty active research is to sort of create a bioengineered blood vessel. And that's really kind of a holy grail amongst vascular surgeons. And I think we're getting close with that. And basically in fact, we're just getting ready to be part of a trial looking at an artificial blood vessel that actually has human blood vessel cells lining it. So it's kind of cultured cells that line the inner lining of this artificial blood vessel. And all these things I think are close, and maybe in our lifetime we'll have those sorts of things, but there's just nothing available today that we can use. But it'll come. I'm convinced that maybe not in the next 10 years, but maybe in the next 20 years or so, those types of things will be available. I don't know if any of you read The Economist magazine, but there was just a great article about really the fact that there's a good chance that medical technology will allow us to live to well into the hundreds. And 120 will be a reasonable expectation at some point. And we're probably not too far off from that. But then you think of all the social issues that come along with that. It's very complicated.
You were saying.
So I'd like to know, a person comes into the ER and they want to ascertain is it a burst aneurysm. What are they looking for, and then I mean, they could be dying so fast. How are those people saved?
Well, the reality is most of the time if it ruptures, people don't survive. Oftentimes what happens when it ruptures, though, is that it stays fairly well contained. The aneurysm, or the aorta, is in a space that we call the retroperitoneum, meaning that it's surrounded by a lot of tissue. And oftentimes when it bursts, it will be contained in this space long enough for you to go in and fix it. It kind of depends which direction it bursts. Because in front of it, there's intestines, there's your whole abdominal cavity. There's not a lot to stop it. So if it bursts forward, most of those people would not survive. But the reality is, most of the time, for whatever reason, it bursts back instead of forwards. And in those situations, people have very horrible abdominal pain, and they can actually be kind of unstable because they've been bleeding. But if you get them quickly to the operating room, a lot of times you can salvage those situations and fix those people. Yeah.
So you were saying that arteries they're lined with muscle, and so as you do like cardio, like you exercise, does that strengthen the muscles in your? I mean, does that have a positive effect on the actual muscle tissue?
Yeah, it's a different kind of muscle. It's not skeletal muscle that contracts like your skeletal muscle contracts. It's smooth muscle. I think exercise is always a good thing. Whether or not it helps your blood vessels, maybe a little bit harder to say for sure.
Yeah.
But it certainly doesn't hurt. And but it's not exercising your arteries in the same. It's exercising your heart, because your heart is skeletal muscle.
But you won't get like buff arteries.
You won't get buff arteries. No. Yeah.
So these tools you were showing, I mean, they seem to be, very mechanical, almost clunky in a way.
Yeah.
I mean, is it just like that on the operating table, or is it?
Well, it's like that here, because I was kind of holding them up in the air.
Yeah, it's kind of
when they're inside a person, they're pretty stable.
Oh, okay.
Person's lying flat. Again, I'm just kind of holding them up in the air, but we have a fairly stiff wire that they're on, so they're pretty stable. I mean, we can be within a millimeter in terms of how we place them. We can be incredibly precise in terms of how they go in, which really, it's really important when you're dealing with something like this, because you got to line up everything perfectly. You've got arteries going to both kidneys, you've got arteries going to the intestines. Everything's got to be lined up just perfectly. If you're off even a couple millimeters, it'll screw the whole thing up. So, but with all the markers that we have on here, with the stability of the devices, with the quality of the imaging we have, we can be really precise in terms of how we place them.
So given the size of the incisions, is this done under general anesthetic, or can you be?
It can be done under just a local anesthetic.
So you can just lie down, watch your own.
Most of the time, we still do them under general anesthetic, just because we don't want people to be moving. We don't want them to cough at the wrong time, or something like that. So most of the time, we still do it under a general anesthetic. But in terms of sort of the strain and that it places on the body, you can certainly do it just with a local anesthetic. So all you're doing is making a little tiny incision in each groin. So most of the time, people can tolerate that pretty well. It's mainly, the general anesthetic is mainly just to keep everything very still so that you can be precise.
Did you ever sew back on a hand or foot?
Well, I've been involved in those types of cases. We sometimes get called in to deal with the blood vessels. So But then there's tendons, there's nerves, there's bone. So that's usually sort of a multi-team effort. There's plastic surgeons, orthopedic surgeons, neurosurgeons, and sometimes we're involved in just fixing the blood vessels. So that doesn't happen that often.
How about amputations? Do vascular surgeons do amputations?
Yeah, unfortunately for people in whom we can't fix their circulation, we do amputations too. I just had a few more slides just to kind of finish up here. If I can get back to the computer. So speaking of trauma, occasionally we are involved in trauma cases. When we think about trauma, there's sort of two different kinds. There's penetrating trauma, which is the guns and knives, and then the blunt trauma, which is just things that happen to people in their daily lives. The penetrating trauma for us is actually probably a lot easier because it's very obvious what the problem is. You got a hole with blood coming out of it, and it doesn't take a lot of intellectual exercise to figure out where the problem is. So it's really just a matter of going through the mechanics of fixing it. The blunt trauma, which is falling off the ladder, car accidents, falling down the steps, those sorts of things, that's actually much more of a challenge because people can look very normal on the outside but have a whole lot of problems going on the inside. So that actually is a much more challenging situation to deal with. Fortunately, we have very good imaging now with CAT scans and MRI and things like that usually we can figure it out. But it is, I would say that's a little more challenging of a situation. And then, even though I said we don't just do varicose veins, we do treat varicose veins. And just to kind of show you a few pictures of that, the thing on the left was actually from the Parthenon. So even back in even back in Greek times, the Greeks built the Parthenon, right? This is a curiosity club, so one should know that. But anyway, even they had varicose veins. So the one in the middle is kind of the big ropey varicose veins, but then a lot of people, I would say everyone, if you look close enough, has those little spider veins, and we treat both of those. For the bigger varicose veins, we have a pretty minimally invasive procedure that we do for that now called a vein ablation. So instead of the vein stripping, where you would just yank the whole vein out, now we do a procedure called a vein ablation, where we put it's like a little laser catheter up inside the vein, and that it more or less welds the vein shut from the inside. So that's I think that's a huge advance actually. It's turned that operation from one.
Just an aesthetic issue, or sorry?
Well, actually, I'll get to that in a second. For many people it is, but I'll show you some situations where it's not. And these are just some examples before and afters when we do these vein ablation procedures. And people can really get a dramatic cosmetic result, but also, people with very severe vein problems can get these horrible ulcerations. And we see tons and tons of these people. In fact, I just took these pictures yesterday because I decided I needed a vein ulcer picture, and we see several of these every day. So obviously for this person, it goes way beyond a cosmetic issue.
What's the cause of that?
This is just from really bad veins. So what happens with bad veins, so veins have little valves in them. And the purpose of valves is to basically allow blood to fight gravity, because blood has to go back from the legs up to the heart. So if your valves don't work, the blood will just go the wrong direction and create huge amounts of pressure in the veins down by your ankles. And what's happening at a microscopic level is that as that happens, the little tiny red blood cells actually will leak out of the blood vessels into the tissue. And your body then has to break down these red blood cells that are outside of the blood vessel. And that creates this kind of very intense inflammatory response, and the tissue gets very hard. You get a lot of inflammation around that area, and eventually the skin just starts to break down.
It's like a bed sore, and that same thing happening from gravity being in.
Yeah.
Is that individual waited maybe a bit too long to come in?
Yeah, there's certainly an element of that. It's for people who have very bad veins, we usually prescribe a real strong compression stocking. And basically what that does is just kind of support the veins that no longer have good valves. If people have a good support network, they can generally manage these very well. But even so, I mean, in some people, these are just, even people who do everything right can get ulcers like this. And it's really a hardship for them. And you can get these to heal, but it takes time, and and some of the vein treatments will help with that, but it just kind of takes a lot of time and a lot of wound care. And then just the spider veins, we typically just treat those with, now these typically are all cosmetic, but you know, a lot of people just want to get rid of them. So we do what's called sclerotherapy, where we inject a solution into the vein that makes the vein scar down. And sometimes we actually even use a laser. Actually, it just works just like a laser pointer and zaps the little spider veins. So, and that's again just some kind of before and after things. Now this takes a couple months to get the picture on the right. When you first do the sclerotherapy, initially the veins kind of get dark and bruised, but after a couple months they tend to fade away pretty well. So that's pretty much it. I just wanted to put up a couple quotes that I think are relevant to what we do. They're both from Proust. The first one says, "It is in moments of illness that we are compelled to recognize that we live not alone but chained to a creature of a different kingdom, whole worlds apart, who has no knowledge of us, and by whom it is impossible to make ourselves understood, our body." And you know, when you see people who are really sick, it's almost like their spirit and their body become dissociated, and their spirit is strong, and they're just so angry that their body has all of a sudden become this foreign object to them that is causing them so much trouble. And then the second one is, "Illness is the doctor to whom we pay most heed. To kindness, to knowledge we make promises only, pain we obey." And that's really true. I mean, in our daily lives, there's lots of things that distract us. But when people are sick and when they're in pain, they are completely focused on that. There is nothing else that they're focused on other than what's making them have pain, what's making them not feel well. And you know, all these gadgets are great and they're kind of fun to play with, but really, as I said, the thing that's most rewarding is just the ability to take someone who is in pain, whose body is not working well, and sort of help them get back, maybe not to completely to normal, but to at least make them better. So with that, thank you very much for the opportunity to talk. And again, if anyone wants to look at any of these devices, feel free to come up. But again, be careful because they're really sharp. Any other questions? All right, thanks a lot. Oh, okay.
All right, we return on August 23rd with William Anthony with his talk, PIR Drag Races on Film, Return to Analog Still Photography. Portland-based commercial and editorial photographer William Anthony was looking for a personal project. While visiting a classic car show at the Portland International Raceway, William heard the roar of dragsters on the nearby strip and was drawn to it like a moth to the flame. Here he discovered a subculture hiding in plain sight. Having recently rebuilt his darkroom after 15 years in storage, William chose to shoot this all on black and white film with 2 cameras, developing it all himself. He will be discussing his challenges, benefits, techniques, and revelations of photographing this niche that is indifferent to being cool or mainstream, only fast. And let's have another round of applause for Dr. Landry. And come up and check this stuff out.